Hi, everybody. This is Dr. Wright. I want to spend some time and explain what lipedema reduction surgery is. So just a disclosure, I'm going to be discussing micro-air instruments, and I have received compensation as a consultant for micro-air. So what is lipedema? So lipedema is a progressive connective tissue disease that affects the subcutaneous adipose tissue of the extremities, causes pain, tenderness, and swelling in the affected areas. And untreated lipedema can lead to lymphatic impairment and disability. So we need to know how do we diagnose lipedema? So we diagnose it with patient history, a detailed physical exam, and ruling out competing diagnoses, such as obesity and lymphedema. So the physical exam inspects for symmetry and proportion. So there's going to be, as you can see here, there's the legs and hips are out of proportion to a smaller waist. Inspect for bruising, palpate for nodules. There's subcutaneous nodules that are in lipedema that are characteristic. We evaluate for a non-pitting edema and stemmer signs. Typically, stemmers are negative, and there should be presence of non-pitting edema. And then assess gait and knee range of motion. So here are the classic cuff signs. There's an ankle cuff there and a wrist cuff here. Now, cuffs do not have to be present, but there is, if they are, that is, there's only a few diseases that cause cuffing, and lipedema is one of them. Lymphedema obviously is another. So it's a big tip-off, but it does not have to be present. Lobules are often seen. They're seen in essentially in stage 3 lipedema, and they are characteristic with extrusions that go away from the normal contour. So here you can see a lateral thigh hip lobule in this lady with lipedema, and a knee lobule. Also here is a upper arm lobule, and those are I mean, they are also seen with obesity, but they're characteristically seen in lipedema in the advanced stages. So lipedema treatment. So lipedema should be treated comprehensively. It's a systemic disease, and on medical grade compression and a anti-inflammatory diet that emphasizes low processed, low refined carbs, limiting refined carbs. Lipedema has to be treated comprehensively. It should not be treated just as a surgical disease, because treating it just as a surgical disease will lead to poorer outcomes, recurrence, and even progression of the disease. So, as I said, it's part of a comprehensive treatment. So in addition, there needs to be medical grade compression. We recommend 20 to 30. The anti-inflammatory diet that I discussed. Also decongestive therapy, exercise, especially water exercise, and efforts to optimize weight or lose weight if needed. Now, the conservative treatment can reduce pain and causes a slight decrease in limb circumference. However, the compression and conservative measures do not improve mobility or knee mechanics. And in my studies and others, the conservatives have not improved all of the quality of life measures that we see with the lipedema reduction surgery. So lipedema reduction surgery has not only been shown to decrease limb size and pain, but also improve mobility, knee mechanics, and quality of life. I'm getting into that a little more later. So it's different from a cosmetic procedure, obviously, because it's addressed at functional, but we also take extra functional improvements and not cosmetic improvements. We also take extra precautions because of the increased risk of lymphatic impairment in women with lipedema. We are extra concerned about the lymphatics, and so the technique for lipedema reduction surgery involves specialized cannula techniques to reduce the risk of lymphatic injury. So that involves mapping the principal lymphatic structures, marking the areas, and prepping the patient, then administering generous tumescent anesthesia. Then there's the suction aspiration. And then sometimes we will, if there's fibrous nodules that were not removed with the lipedema, we will remove some of them, some small nodules that are left. And then finally, compression. And compression is critical to successful lipedema reductions surgery. So as I said, it's a derivative of cosmetic liposuction, but it uses essentially the same tools. I use the micro air power assisted liposuction. Now, why do I like the micro air? Because it allows for me to maximally debulk the tissue. So we have to really we want to remove all of the diseased tissue and the fibrous tissues. And while it can be removed with just classic tumescent cannulas without any vibration assistance, the vibrations of the micro air allow me to get more and to get it with less fatigue. These are long procedures. They're much longer than cosmetic procedures. It's 4 or 5 hours is not unusual to get all the tissue in the areas of the surgery. Again, we're focused on functional gains, and so these lymphatic principal lymphatic collectors that have been mapped and identified. We want our cannula strokes. We want to focus so that we're longitudinal to them instead of transecting them. So this really has come through some studies, some anatomy studies and lymphatic studies that show that these principal lymphatics are relatively are tolerant of the longitudinal stressors around them, but can be transected when with transverse. So this was done in cadaver studies with lymphocystograms and lymphatic dye studies. Here on this slide, we can see these are the principal lymphatic collectors on the legs, and they can see they follow the path of the they're on the on the fascia, following the path of the saphenous system along the medial leg and also on the lower leg, and there are some that also go back around the small saphenous. So that's where location of those is part of the best practices for treating lipedema. So this is so using that, and I've described lipedema. I've described my surgical technique, and now I want to talk a little about lipedema reduction surgery. I published the functional gains and mobility gains that we see with this, and this was awarded the best reconstructive surgery paper of 2023. Just recently been notified of that. So it's also the first to look at lipedema reduction surgery in the United States, first to document joint improvements, gait improvements. It correlates patient-reported outcomes with objective physical measurements. It shows improvement in mobility that correlate with future disability and life expectancy. And in it, we chose outcome measurements that are used in the orthopedic literature. So when we were looking at the knee flexion capabilities or the mobility improvements, we can compare them to a total knee replacement using these same measurements, and it actually was equal to, or really by the measuring tools better than um, the total knee replacement. So this is a look at these knee range of motion, and you can see before there's a lipedema before the lipedema reduction surgery. There's a decrease in knee flexion, and that improves after the surgery. It's a little less than 10 degrees. And there's a misalignment that occurs, a valgus misalignment in the knees that is around close to 6 degrees before surgery and improves to about half that after surgery. And we also looked at some other measurements that didn't significantly change. But we did see an improvement in gait. And so about 80% of women prior to surgery had an abnormal gait, and that improved to just 20% had an abnormal gait after 6 weeks after the surgery. This is how we measured the changes, and so you can see here that this is how lipedema tissue restricts the knee flexion. So this is a lady with lipedema, and there's her knee flexion. And normal, so the red arrow is where she is, and this middle arrow, it's actually green, would be what normal is. So the normal flexion in an untreated is hard to reach for an untreated woman with lipedema at this degree. And this is showing that valgus. You can see here that there's a angulation of the knee. The knee's supposed to be straight up and down, and you can see there's an angle of the from the femur and tibia. Okay. So how does that work? What's the so if our average lady with lipedema is around 120 degrees of flexion, then she's going to be limited in getting out of the car or bathtub, and may also have trouble running or other activities. And if they're even more limited by the lipedema tissue, can affect going up and down stairs. Now, we see here that we saw those improvements I showed you in their mobility, and this is a composite score of the mobility, and you can see here that there's a highly significant change in their overall ability to do activities. And I'm going to go into the specifics of what went into that composite right now. So 16, based on these promise measurements, there's a 16% ability for patients to walk at a normal speed. This improvement correlates with longer life expectancy. There's a 16% ability to go up and down stairs, based on the NIH promise outcome measures, and also this is also associated with improved life expectancy, and a 27% increased ability to run at a short distance. These also are associated with decreased rate of disability. So while the improvements are improved life expectancy, on the other hand, people untreated are at a greater risk for developing disability. These patients report also there is an increase in ability to stand for an hour. We also looked at using this SF36. We looked at all these global domains of health, including physical function, energy and fatigue, social functioning, pain outcomes, and general health. And all of them significantly improved. So there's a 12.5% decrease in overall body pain, a 12% in overall health, 11% ability to handle activities of daily living, and a 13% ability to complete tasks that were previously limited by physical pain. Now, also, the lobules that are seen in lipedema in stage 3 decrease significantly. So prior to surgery, about 90% of women had thigh lobules, and post-surgery, a very small percent had thigh lobules, and similarly seen in both inner and around the knee and in the arms. Now, what that means is that we can see if before the surgery and after the surgery, if the lobule is gone, and here we can see the knee lobule before and after surgery. If those lobules are gone, and those lobules are the key differentiating factor for lipedema reduction, for lipedema stage 3, then we can argue that there is a regression of lipedema stage from this lipedema reduction surgery. So this is a surgery, and all surgeries have complications. Now, there are, when treating lipedema, they're a little different from those of cosmetic liposuction. Because this is a larger volume and maximal debulking, there's a slightly increased risk of blood loss. And we recommend, and we also not only recommend, but in our practice, we treat varicose veins pre-op. If there's large varicose veins, that's going to increase the risk of significant bleeding, and it's best to do that. All women with lipedema have an increased risk of DVT. It's about 2 to 3-fold. So there's a vascular component to lipedema, and we're just really learning more about that. But that is not really, that's independent of the weight. There is several studies show that with both lymphedema and lipedema, that there's this increase, 2 to 3-fold increase of DVT. So we do recommend prophylactically, if they have significant any other risk, we put them on blood thinners or aspirin postoperatively to reduce the risk of postoperative DVTs. And then, we take the precautions to um, reduce the risk of lymphatic injury because they are at increased impairment. So now this was not this is a patient with lipedema, and she had surgery with another surgeon, and she developed um, lymphedema in her leg. You can see here, this is her right leg. There's she's loss of the she's got swelling and loss of the landmarks, the bony landmarks from her lymphedema. This is she developed this post-operatively, and she has a positive stemmers, though you can't really tell that just from the picture. This is her lymphocinogram, and you can see here that there's clearly delayed uptake in the right lymphatic system. And so, this is very, uh, very unfortunate for this young lady. And so we want to do everything we can to not have any of these complications at least in my practice. Thank you very much for your time. I enjoyed speaking with us. If you have any questions, please put them in the comments.